Please welcome National Conference Planning Group moderator, Dr. Jennifer Miller.
Good morning. Wasn't that wonderful? Just a little plug, as Dr. Schreier mentioned about the plight of immigrant children being held at detention centers. Don't forget to stop at the site outside and make a butterfly to signify the 15,000 immigrant children being held at detention centers around our country. This morning, I have the pleasure of introducing our next speaker, Dr. Megan Sandel, who will be presenting Home Sweet Home. Stable, affordable housing is a prescription for good health. She has served as a principal investigator for Children's Health Watch and is the associate director of the Grow Clinic at Boston Medical Center and associate professor of pediatrics at Boston University Schools of Medicine and Public Health. Please join me in welcoming Dr. Megan Sandel.
Hi, everyone. Good morning. I'm really thrilled today to be able to talk to you about why I think a stable, affordable home is really a prescription for good health. I'm going to try and kind of take you on a bit of a journey today. I have nothing to disclose. Our learning objectives today will hopefully be to talk about what are the ways in which housing impacts health. I tend to talk about it as the 4 dimensions or the 4 walls of which how housing impacts health, right? Quality, stability, affordability, and location. I'm going to hopefully talk about how we can take action, both at the screening, systems, and policy levels. And then what are the ways in which we can now think about exploring new messages that can be most effective to make the case for homes as a route to health equity. So let's get started. We talk a lot now about social factors, and I think this is really amazing because we as pediatricians honestly have been talking about social factors for decades. Welcome the rest of the population to talking about it. But to an extent, I like to highlight 3 things that I think are really important. We sometimes talk about them as social determinants of health, but in the end, they don't determine your destiny. They are not fixed, but rather fixable. We have to be able to talk about them in ways that are not necessarily as just a single factor, but there actually are multiple factors together. So we don't just talk about food, we'll talk about education, and we'll talk about housing. And then I think the other piece is that they're not always negative. Sometimes they're positive. In my children, they have great social factors. They have 2 parents that are doctors. They live in a house that we own. They're in a great school system. And so as we talk about them, don't always talk about them as the negative. Sometimes talk about them in positive terms. As we think about ways in which housing impacts health, I like to use Lauren Taylor's piece in Health Affairs because that is a piece that really highlights those 4 areas. We as pediatricians know housing quality has been important, again, for decades, right? Lead poisoning, asthma and exacerbating conditions there, things like childhood injuries and other things. We now recognize homelessness, but we know now, and I'll go into this in more detail around stability isn't just being homeless. There may be instability that is in other factors that may be just as important. And we know a lot of that is the root cause related to affordability. We know there's a huge affordable housing crisis that really affects a lot of our patients and has reached kind of epidemic proportions. And then lastly, we focus a lot on neighborhoods. What are the ways in which neighborhoods are really determining a lot of factors that are important for us, not just as a pediatrician, but as our health system and a policy level? All right, so let's dive in deeper. So for those that are not familiar, Children's Health Watch has been around for 20 years. This is a research network of pediatricians and policymakers where we have collected data across 5 cities in Boston, Baltimore, Philadelphia, Little Rock, and Minneapolis. We're really focused on what are the policies and conditions that impact the health and development of young kids, things like food insecurity, housing instability, energy insecurity, healthcare cost trade-offs. Over the last 20 years, we've interviewed over 65,000 families, published over 40 to 50 peer-reviewed journals and others. And those are ways in which we try and bring that data from the front lines to policymakers to try and make better policies that promote child health and development and healthier families. One of the things that we've been focused on is around homelessness, right? We've published that, yeah, if you're homeless when you're pregnant, you're more likely to have a premature baby or a low birth weight baby. As you think about it, there are also then issues related to infancy, and being homeless during infancy is a really critical window with really extremely bad health outcomes. And then we recently published in pediatrics that it's not just the timing of it, but the duration that matters, and that being pregnant and being homeless carries over into childhood, even after you control for the birth outcomes. But we know that homelessness is not the only issue here. And so we are now thinking about the housing stability iceberg. And so we focus a lot on the part of the iceberg we can see, which is homelessness, but we know that there's a lot of iceberg below the surface. People that are hidden homeless, that are doubled up, multiple moves, that are having overcrowding and other things, and that we think that that root cause oftentimes is the lack of affordable housing. And so in 2018, we actually published in pediatrics how unstable housing, 3 forms of unstable housing, impacted both caregiver and child health. Now, in this kind of bar graph, there is the stable housing, which is that green bar, right, where there's no risk associated. And then we're looking at what's the adverse risks that are associated with child health and maternal health, maternal depression, things like food insecurity, energy insecurity, or healthcare cost trade-offs. Now, as you see in the yellow bar, that is the adverse risk associated with homelessness, right? And we knew that homeless kids and families would look like they had adverse health. What we were surprised at is that that blue bar is the one that is the families that are reporting being behind on their rent in the past 12 months. And as you can see, we knew that homelessness was bad. We didn't realize that behind on rent would be just as bad. And so as you think about kind of, are we going to improve the health of kids? How do we do that? We do that through both ending homelessness and ending behind on rent too. So that is important as we try and think about what are the ways in which we can try and help our patients get that stable, affordable home that's the prescription for good health. I think the last area, I've talked about quality and stability and affordability. Let's talk about location. So this is a map of the city of Boston. And what we've done here is we have highlighted something called the Child Opportunity Index, which is developed by the Kirwan Institute. And what they do is they grade neighborhoods on a 5-point scale from a very high opportunity neighborhood, which is dark red, to a very low opportunity neighborhood, which is the light yellow. And so what you see here overlaid in the development, and you can actually see these maps online. If you go to diversitydatakids.org, you can actually pull this up for any of the cities that you work in to be able to see what does the opportunity map look like. But in this, one of my colleagues at Boston Medical Center, Dr. Renee Boynton-Jarrett, she went to our electronic health record and she pulled the blood pressure readings of 3-year-olds. And she looked at the prevalence of kids having an elevated blood pressure above the 95th percentile. And the larger the circle is the higher the prevalence of those elevated blood pressures. And what you see here is that you have bigger circles in the lower income neighborhoods, in the neighborhoods with less opportunity. And so as we think about it, this is how kind of the social factor becomes biologic. This is how neighborhoods with less opportunity actually plays out in how to think about the biology of how kids may get sick. And so for us, we published this in Academic Pediatrics in the special edition journal on child poverty, and argue that we can't just do individual level interventions. We have to do neighborhood level interventions to lift kids out of poverty. So as we think about these factors, right, we think about quality, stability, affordability, location. How do we integrate them into practice? And so I like to think about it as like the cogs in the wheel. We can do things like screening on the front lines. That's one cog. We can do systems change and start to link together to create partnerships. We can actually help our health systems themselves actually start to act as healthcare anchors. And we can actually then do policy change, because that's the biggest cog, that has the biggest impact. So let me just walk through a few examples. So at Boston Medical Center, we instituted what we call our Thrive screening tool, built off of the great research of Dr. Arvind Garg and the We Care model. And what we did is we created a single screen, like a single piece of paper, 10 questions. Anyone who walks through our hospital now gets it, whether you're a pregnant woman, a child, an adult. And what we do is then we take that and put it into our electronic record. What we try to do now is say, okay, yes, we can give you a resource list, but we know that especially in housing, there may not be a lot of resources. What's like a medium dose type of partnership that we can create? And so we've co-located on site a housing support agency where they've essentially set up an office at our pediatric clinic, Metro Housing Boston. And now when you do the screening tool and you especially have certain issues, we now can send you directly to the on-site housing worker. We also have been blessed. We're one of the founding sites of Medical Legal Partnership. So we have our on-site medical legal partnership that if you have an imminent eviction or other things, we can do that kind of response and be able to serve you. So that's kind of a medium dose sense of how you start to set up systems. We also have started to pilot test a housing prescription as healthcare program. And in that, it's where you have a hospital and a health plan referring patients of medically complex families, where someone in the household has had 3 ER visits in the past year. And you say, this family is more expensive, they're housing unstable or homeless. How do we put together a set of partners, a rapid response team that can therefore help someone get to more stable housing, improve their health, and reduce their costs? And so in this, you see the center is actually a community-based organization, Project Hope, where we identify the families, we consent them to be part of this. We're actually testing it as a pilot randomized controlled trial to see what an actual housing prescription means. And then we have the family be able to get not only financial coaching from our local community development corporation, Nuestra Comunidad. We also have our medical legal partnership, help them stabilize if there are legal issues. And then the crucial part is we have partnered with our local public housing authority to be able to actually help prioritize these medically complex families to potentially get a affordable housing unit. And so as we think about that, these are the types of programs that any community could put together with the right orchestration and to be able to serve families, change trajectory, and reduce costs. One of the things that we as Boston Medical Center have started to do is to think of ourselves as anchor institutions. And so we recently made a $6.5 million commitment to a housing initiative to both improve community health and to start to think about ways in which to make patients healthier and reduce their costs. For those that are familiar, the Democracy Collaborative orchestrates actually a healthcare anchor network of 40 different large hospital systems across the country, which is really trying to use your economic power as a institution to employ locally in the community to help people with a job. Some people may have seen the New York Times actually featured this recently. We also then can procure, we can buy things from local businesses as a way to support community health. We can invest in community, in affordable housing, in starting new grocery stores in low-income neighborhoods, where the biggest thing between them is financing, where we can use our investment portfolio as a social impact portfolio to change health. And we can weigh in on policies. I think one of the things that pediatricians ask me all the time, what can I do? You can ask your institution, why aren't you part of the healthcare anchor network? Because that is a way in which we can act together in order to change our communities through investing and as a route to health equity. The last part I want to talk about is I think we as pediatricians are the best messengers out there, right? We are doctors talking about our patients and advocating not just for ourselves, but really for our patients. And that makes us incredibly effective. But I sometimes think we don't always choose the best messages. We sometimes will focus on really negative storytelling, right? The patient who's really sick and they're doing really poorly, and that's why you need to make this investment. And I'm going to encourage you to try and have a positive frame in the future. More and more, we have to have new metaphors for how we talk about it. This is one that we've started to test out, which is a metaphor of talking about child development as that seedling tree. And that growing tree needs to live in a community that has nutrients, that has stability, that helps kids grow roots and be able to grow strong. Very similar to Dr. Kamara Jones and how she talks about describing inequities. In this way, we set a positive vision for why kids need to be stable, why they need to have an affordable home, and that is the way in which you're going to have strong kids for the future. I think that the other piece that becomes really important is that people talk about costs all the time. It costs too much. Well, I think it's important that we talk about avoidable costs, because we know that there's a lot of costs that we're incurring right now related to it. And so we, in that paper that we published last year in pediatrics, we actually did a congressional budget office style assessment of what are the avoidable costs in maternal and child health if every family had a stable home over the next 10 years. And we think it's $111 billion. So as you think about it, when people say to you, oh, doctor, I don't know whether or not we can afford that, you could say, that implies we're not spending that money now. And so we need to be able to talk about both the positive frame and the potential savings that we can have in the future. The last piece is that I encourage us to start joining campaigns. Children's Health Watch joined the Opportunity Starts at Home campaign, which is 12 different organizations on our steering committee that are committed to trying to bring sectors together in order to bridge the income gap between what housing costs and what people's incomes are, to provide people who are experiencing emergency shocks with the resources to avoid evictions and to be able to be stabilized, and to build and expand the affordable housing stock. This is with organizations like the Children's Defense Fund, the different types of education organizations, the National Education Endowment, and others that have joined together with housers to make this case. And I really encourage that those people that want to learn more can go to the opportunityhome.org and sign up. I think that more and more we are talking about moving upstream. And so I think as we think about it, we as pediatricians oftentimes are focused on prevention. And I think that trying to be able to talk about what are the ways in which we obviously are going to help patients downstream that are suffering with disease and injury and intervening. But what are the ways in which we can go upstream to do systems and policy level change to try and do it, to ask our systems to act differently, and to invest and to talk to policymakers about bringing new resources. I think, as I like to end every talk that I give, is talking about equity. So in this cartoon, and there are a lot of different cartoons, some people may have seen the ones with the people looking over the fence to the baseball game, or Robert Wood Johnson has a new one with people on different size bikes. I like this one, which is basically talking about equality doesn't mean equity. And what this is where you have different heighted people. You have people that are tall, medium, and short. If you treat them all the same, you give them one box to stand on, then the tall person gets to that apple of opportunity in the tree. The medium height person gets closer. The short person gets close, but is not that close. It's only when you treat people equitably, you give people what they need in order to get that same fair shot, that access to that apple of opportunity. You give the tall person one box. You give the medium height person 2 boxes. You give the short person 3 boxes. Then they all get that same fair shot. And so the tension with equity is that you have to treat people unequally. You have to give some people more to get that same fair shot. And you have to acknowledge that people didn't get to be different heights by accident. Structural racism and oppression have changed where people start from. And that equity is how we change that so that everyone gets that same fair shot. And so, yeah. So I hope that in this brief journey, we've talked a little bit about ways you may be able to change your practice. Think about screening for housing insecurity and quality problems. I know it's hard when you don't have a resource right available, but I assure you that your patients will want to talk about it because it's on their minds. And there may be ways in which you can align your practice and be able to build more security within your health system to want to do this by having that data. I think that making housing partnerships are possible, co-locating things that already exist in the community that you can put on site, being able to ask your health systems to act like anchor institutions. And I think that we always have been advocates as pediatricians, but I think we can be even more effective to be able to bring new messages to why affordable housing is the solution to child health. And so with that, I just want to thank you very much for your attention. Thanks.